Hello, my name is Orly Vardeny, and I am a pharmacist at the Minneapolis VA Center for Care Delivery and Outcomes Research and an associate professor of medicine with the University of Minnesota. And today we're going to be talking about patient engagement with influenza vaccination. We are all aware that influenza leads to significant morbidity as well as mortality. Shown on this slide are data from the Centers for Disease Control and Prevention. These are publicly available, examining risk factors for influenza hospitalizations between 2014 and 2018. And what's clear is that the majority of patients that are hospitalized with influenza have at least one chronic health condition. The take-home message is that patients with underlying health conditions such as cardiovascular disease are at an increased risk for being hospitalized or having complications from influenza infection. So while we know that influenza vaccine reduces the risk for influenza, does influenza vaccination also protect against the risk for major cardiovascular events? And in this meta-analysis conducted by Jay Udell out of the University of Toronto and published in JAMA in 2013, receipt of influenza vaccination was associated with a 34% reduced risk of major adverse cardiovascular event, with a number needed to vaccinate to prevent one of these events of 58 individuals. That number goes down to 8 number needed to vaccinate to prevent an event among individuals with recent events like recent acute coronary syndrome. So what is the uptake of influenza vaccination among patients with cardiovascular disease? These are data from the Get With the Guidelines Heart Failure Registry, looking at hundreds of hospitalizations and in heart failure patients between the years 2012 and 2017. And what's shown in the blue is a slightly reduced frequency of influenza vaccination. And what's concerning is an increased risk in the green on top of refusal to be vaccinated among individuals with heart failure. And this is concerning because we know that this group of individuals is at high risk for influenza-related complications. When we look at racial disparities of influenza vaccination, and these are cross-sectional data from 2016 to 2019 from the Behavioral Risk Factor Surveillance System, and this was a cohort of about 1.7 million U.S. adults. That was a nationally representative sample, and it was a telephone-based survey. And what was shown is that the vaccination rate among Blacks and Hispanics were much lower compared to white individuals. And alarming again was that only 50% of patients with ASCVD received influenza vaccination during the study period. So why is that? What are some reasons that patients tell us as providers for why they are hesitant to receive influenza vaccination? The number one reason that I hear from my patients is that influenza vaccine causes the flu. And this is because of likely the minor side effects that accompany receipt of influenza vaccination. These should be expected and the patient should be educated on these so that they know when they occur, it doesn't mean that they actually have the flu or influenza, but as a normal reaction of a part of the vaccine. Another reason is influenza vaccine doesn't work. There are sometimes reports in the media about vaccination efficacy or effectiveness varying from year to year. And while that is true, I think the underlying message to patients should be that despite varying effectiveness, there's still a protective effect each year of influenza vaccination. Another one is I never get sick, therefore I don't need a flu shot. One thing to educate patients on here is to let them know that protection with the vaccination protects potentially them from getting sick, but also others, and especially other vulnerable individuals like older adults. I'm allergic to flu shots, so these are often can be confused with some of the mild adverse reactions to the vaccination, can be confused with allergy. And then some media reports in the past of influenza vaccine causing harm. There have been some reports or media hype relating to influenza linked to autism. which of course has since been diffused or debunked, but patients are still aware of this and may bring this up. So what are some potential counseling points? We talked about a few of them in the previous slide, but one thing or a few things to emphasize to patients is that influenza can cause serious disease and even death, and especially in high-risk individuals, such as those with cardiovascular disease. And although we're in the midst of a COVID-19 pandemic, influenza virus has been previously responsible for global pandemics. And this is not too unusual. There have been 4 since the 1918 Spanish influenza season or influenza pandemic. We can convey that although influenza might be linked or thought of as a respiratory condition, we need to keep in mind that influenza worsens any underlying condition, and that the reason that people with concomitant conditions such as cardiovascular disease are at such an increased risk is that influenza is a destabilizing force and therefore will worsen underlying concomitant conditions or exacerbate concomitant conditions such as heart failure. And even during years of lower vaccine effectiveness, influenza vaccine still is protective in terms of cutting down on the severity of illness if a patient does become ill, reducing the risk for hospitalizations and even death. We need to educate patients on what some of the effects, the injection site reactions are from influenza vaccine. The muscle aches, potentially headache, that can occur for about 24 and maybe even up to 48 hours. If patients are aware of this ahead of time, they know to expect them and then will be less alarmed when they occur. And then lastly, as mentioned, the importance of getting vaccinated to protect other vulnerable people who may have an increased risk for complications such as secondary pneumonias or hospitalization from influenza infection. One thing we can talk to our patients about is that although they might hear about varying efficacy of influenza vaccination, the efficacy is still, no matter what year of influenza vaccine is given, the efficacy is still in line in terms of protection from other agents that we commonly think of and commonly accept as reducing risk. And these include things such as tobacco cessation, use of statin medications, renin-angiotensin-aldosterone inhibitors. All of these, the reduction in risk for myocardial infarction is in line, or the risk for reducing myocardial infarction with influenza vaccine is in line with some of these other well-recognized, well-accepted treatments. One of the key aspects to successful influenza vaccination campaigns is access. And this is so important to be able to offer patients multiple options for where they can obtain their influenza vaccination. This should not just be limited to primary care offices, but also to other specialty clinics, even cardiology clinics. I'm a firm proponent of influenza vaccination being offered to patients wherever there can be a touch point with a healthcare provider. So if the patient happens to see a cardiologist more frequently than they might see a primary care provider, it's important to be able to offer the opportunity for vaccination during those visits. Patients can be reminded that a lot of local pharmacies are also able to provide influenza vaccination as well as other vaccinations. And then a lot of influenza vaccination campaigns do occur at patients' place of employment. But again, reinforcing that there are multiple places for patients to become vaccinated. The more convenient it is to become vaccinated, the more likely it is the patient will do it. So wherever a touch point is for that patient, whether it's at work or at a clinic setting, the ability to provide that opportunity is really crucial. In summary, we know that influenza leads to significant morbidity and mortality, particularly among those with underlying health conditions such as cardiovascular disease. Influenza vaccination has been shown to reduce the risk for these cardiovascular events. But we also know that uptake of influenza vaccine among these patients is suboptimal. So this requires that we educate patients, that we provide education on some of the myths about influenza vaccine that tend to be common among these patients, and implement novel implementation or use novel implementation strategies for increasing uptake of influenza vaccination. And then lastly, cardiology practitioners should take a more active role in promoting receipt of influenza vaccine and potentially vaccinating patients in their own clinics when that is feasible and available. Thank you so much for your attention.